Handoff problems constitute one of the top issues more prevalent in malpractice cases involving trainees as compared with non-trainees, along with lack of technical competence, lack of supervision, and excessive workload. Issues surrounding handoff occurred between trainees as well as between trainees and attendings. In their discussion, they suggest that communication skills may be underemphasized in residency with lack of formal teaching on this matter.
That's Dr. Sophie Greenberg, and this is Dermatology Weekly by MD Edge, where we bring you news and developments in dermatology and peer-to-peer conversations with dermatology experts. I'm the voice of MD Edge Podcast's Nick Andrews. Today, in residency, transitioning care to different providers can be a complicated process. Dr. Vincent DeLeo talks to Dr. Sophie Greenberg about strategies to improve patient handoffs among dermatology trainees. And Dr. Greenberg identifies key issues that may hinder patient handoffs. And she also offers evidence-based solutions that can help keep dermatology residents organized. We're also bringing you some of the latest on COVID-19. First, the American Academy of Dermatology rolls out best practice guidelines for clinicians faced with rapidly evolving patient care delivery and reimbursement challenges caused by COVID-19. And Dr. Adam Friedman of George Washington University in D.C. outlines how his institution is prepping itself for a sharp rise in teledermatology needs. Remember, if you have feedback or suggestions on the show, you can email us at podcast@mdedge.com. We're also available on Twitter at mdedgederm. You can find the email address and Twitter account in the show notes. And now, the news. The American Academy of Dermatology has issued guidance and a roadmap to key resources for dermatologists faced with managing patient care delivery and reimbursement in the era of COVID-19. The Academy's guidance is publicly viewable, and the AAD has made a collection of COVID-19 articles on the Journal of American of Dermatology freely available for the next 6 months. Dr. George Hruza is the AAD's president-elect and a dermatologist in Chesterfield, Missouri. He says plenty of questions still need to be answered, but the AAD ad hoc task force will offer ongoing guidance and information throughout the COVID-19 crisis. Among the pandemic-induced regulatory changes, CMS has relaxed key technology rules to allow telemedicine visits via platforms such as FaceTime and Skype. The usual fines for HIPAA noncompliance have been waived, and those telemedicine regulatory changes apply to patient encounters for any purpose, not just coronavirus-related encounters. Plus, telemedicine visits can now be reimbursed at the same rate as in-person visits. Dr. Hruza says private payers are beginning to follow the Fed's lead on telemed. The AAD is tracking which payers are coming in line with federal policies on its teledermatology page. The AAD has also been developing guidance on how to address the COVID-19 concerns of patients taking biologic therapies. For patients on biologic therapy who show no signs of coronavirus infection, the AAD says the decision to continue or stop biologics should be made on a case-by-case basis. Consider factors such as patient age, comorbidities, and the severity of the biologic's original indication. For a complete look at the AAD's COVID-19 guidance, you can click the link that's available in the podcast notes. And with the spread of coronavirus containment efforts, the traditional face-to-face op-ed visit is rapidly vanishing. But what will it take to replace those patient visits with virtual teledermatology consults? Dr. Adam Friedman is professor of dermatology at George Washington University in Washington, D.C. In an interview with MD Edge editor Terry Rudd, Dr. Friedman talks about how his institution is preparing for a surge in teledermatology. And he also discusses what dermatologists should remember when they make those virtual connections with their own patients.
What are you guys facing?
Yep.
Where are you, and what are you looking at having to do to get up to speed?
I'm actually going to probably pilot telederm visits, which I'll describe in a second, next week. But you're right, the ramp up has been clearly in connection with social distancing associated with COVID-19. Right now, in terms of live visits, we're only seeing urgent or acute cases, which we're talking about maybe 3 or 4 a day at most. But we have lots of patients that do need to be seen, and telemedicine is going to be the best way to do that and safely do that. So what we mean by telemedicine or teledermatology is we will have a tablet that we will, using Zoom probably, have a conversation like you and I are right now, either myself or an MA will be scribing the visit as though the patient were there. And actually our tablets are on these stands with wheels. So it's almost like this little stand with wheel and a tablet is the patient. And we almost treat them like that in terms of the communication, how they're triaged and brought in. So I'm gonna pilot probably starting on hopefully Wednesday, and then we'll span from there. Now your point about, well, rollout and scale up is somewhat difficult. And I agree, we have 2 tablets that we use for translating services. That's clearly not gonna be enough even for one practitioner. This, I'm hoping will come to fruition and be solidified in the next 24 hours, but we are working with Microsoft, who is going to donate 200 of their Surfaces to serve that function, which will be very exciting news. We had our first call about it today, and we actually might even start with 60 starting tomorrow in terms of spacing those out and handing them out to the different departments with the greatest need. So yeah, it's more about not just can you do it, it's you have the infrastructure that allows you to do it at a scale that really mirrors what you're doing with your standard practice.
Anything you'd want your fellow dermatologists to know about attempting telederm, about making that leap from face-to-face to we're Zooming?
I mean, it's certainly scary. It's different. And, I think inherently we are not into the idea of change. The good news is telederm is not a hugely novel concept. It's been percolating throughout dermatology for quite some time. It's more that it's never been to this scale. You hear telederm, you think of Kerry Kovarik and colleagues who are doing, across the world type of communication, or some of these companies that are doing more kind of anonymously associated, kind of telemedicine. But this is going to be a big challenge, especially for those who may not be so tech savvy. So I think in a time of great need and crisis, we got to step up. The world is looking to us to show that we can try something new to better impact overall care. And so there will be growing pains, no question. I'm sure I'll experience them myself, but we have to be really willing to take that painful journey to get the job done.
What sort of effect, or what would you want folks to think about when it comes to regulations and telederm? Or has there been some loosening?
They've got to kick to this wind. CMS has come out and said that they're foregoing the standard kind of HIPAA issues, and even a lot of insurance are coming out and saying that they will reimburse the same rate as a live visit, or you don't need to have a license in the state where the patient resides. So I don't know. It's like Wild West, which we need, but they're going to have to kind of reel it in, or else we're going to have people taking advantage of that leniency.
And we'll be right back after this message. Welcome back to Dermatology Weekly. I am Nick Andrews. It's time now for Peer-to-Peer. Please welcome Dr. Vincent DeLeo and Dr. Sophie Greenberg.
Today we're talking to Cutis resident corner columnist, Dr. Sophie Greenberg, about her latest column on handoffs in dermatology. Dr. Greenberg is from Columbia University Medical Center in New York City. Thank you for joining us today, Dr. Greenberg.
Thank you so much for having me today.
So let's get started. In your column, you talk about how problems with handoffs or transitioning care to another provider have been associated with malpractice cases involving residents. What did you find in the literature?
So Singh et al. Analyzed malpractice claims from 5 insurers between 1984 to 2004. They specifically focused on a subset of 240 cases that involved trainees. Medical residents were involved in 87% of these cases, and 30% of the total cases analyzed occurred in the outpatient setting. Handoff problems constitute one of the top issues more prevalent in malpractice cases involving trainees as compared with non-trainees, along with lack of technical competence, lack of supervision, and excessive workload. Issues surrounding handoffs occurred between trainees as well as between trainees and attendings. In their discussion, they suggest that communication skills may be underemphasized in residency with lack of formal teaching on this matter.
So how can electronic health records help to improve the process for handoffs?
Many electronic health record systems have built-in functions to assist with handoffs. Some medical records have the capacity to assign proxies, which allows for a seamless transition when a resident switches to work at different clinical sites. In some but not all electronic health records, clinicians may send themselves reminders or mark results as unread, which can help keep track of outstanding follow-up tasks.
And what other kind of electronic tools can help, do you think? You talk about the List Runner app. Tell us more about that app and HIPAA compliance.
So there are several applications that can help providers collaborate and stay organized. In my article, I discussed a study that came out of the Royal Melbourne Hospital Department of Dermatology in Australia. They created their own HIPAA-compliant electronic handoff system using Microsoft SQL Server and Microsoft ASP.NET interface. Microsoft Teams is a collaborative app that is readily available and allows for HIPAA-compliant sharing of documents and messaging, among other features. List Runner is a HIPAA-compliant app that is free for clinicians and allows you to create collaborative sign-out and task management.
You know, trainees love mnemonics. Are there any tips like mnemonics that can help?
Yes. So the official mnemonic at my hospital is IPASS: illness severity, patient summary, action list, situational awareness, and synthesis by receiver. In dermatology, this might mean providing a one-liner, instructions to follow up on labs or culture data with contingency plans, like if culture positive, start mupirocin 3 times a day for 7 days. With electronic sign-out, it may be hard to implement the synthesis by receiver portion, but my co-residents and I are good about remaining available to ask one another questions.
Great. Now, in your research, you talked about internal medicine inpatient setting, outlining best practices. So can you review those findings and how they might apply to dermatology?
Yes. Standardized tools, including use of mnemonics, have been extensively studied in internal medicine and inpatient settings. For example, Vidyarthi et al., based on a literature review and their experiences in an academic internal medicine setting, highlighted strategies to improve handoffs that I believe may be easily implemented in the dermatology setting. This includes organizing your content using mnemonics, a computer-assisted vehicle, closed-loop verbal communication, and a supportive institutional culture such as prioritizing time for sign-out.
So what do you guys use in your program?
We have similar practices at our 2 main clinic sites, the New York Presbyterian Columbia Clinic and the Bronx VA Clinic. At both sites, we are able to assign proxies within the electronic health record so the appropriate person receives results when we switch rotations. We also have biopsy logs at each site contained within an Excel file, which provides some healthy redundancy to ensure we do not lose track of any skin cancers. At Columbia, we also maintain a shared Word document with additional information on our more complicated patients. These are saved in Microsoft Teams, a HIPAA-compliant platform that allows for collaborative access to these documents. I also keep a notebook with stickers of each patient I see and jot down things to follow up. At the end of each day, I double-check and periodically update my electronic handoff.
This has been a marvelous discussion of a problem that affects all residents in training. But on a personal note, there is a really creative illustration accompanying your article online. Is this a hobby of yours?
Thank you so much. I've always had a creative side and even spent a year before medical school painting full-time. Now I love to use watercolor to make illustrations to accompany my writing. Listeners can check out the full article on Cudis's website to see my illustration, which shows 2 physicians passing off notes to one another as if they were in a relay race.
That's really cool. So thank you so much for doing this today. And do you have anything else you'd like to mention?
Thank you so much. I hope that this helps residents who are trying to stay on top of everything think of ways that they can get more organized and implement some solutions into their program.
Okay, thanks again.
Thank you.
And that's a wrap for this week's episode of Dermatology Weekly. Remember, there are robust show notes available wherever notes are found in your app. let's get to this week's credits. Dermatology Weekly is produced by MD Edge editors Elizabeth Meshkati and Melissa Sears. The peer-to-peer portion of the show is produced and hosted by Dr. Vincent DeLeo, as well as Melissa Sears. The news portion of Derm Weekly is produced by Elizabeth Meshkati, Terry Rudd, and myself. Stories were originally published online at mdedge.com. All MD Edge podcasts are produced by MD Edge and Medscape Editor-in-Chief Dr. Ivan Aransky, as well as executive editors Kathy Skarbeck and Mary Ellen Schneider, and multimedia editor Terry Rudd. Dermatology Weekly is produced and engineered by Tyler Mundek. Social media is produced by Kyla Clark. For all of us here at MD Edge, I'm Nick Andrews. You're listening to Dermatology Weekly.